Good morning, everyone. Today's topic is about movement disorders. One of the common things that you see in your clinical practice, or if you are a student, when you are in neurology postings or even in general medicine postings, a patient comes to you or to your professor walking jerky movements like this. You may think that in initial phases, what are these awkward movements? But over a period of time, you realize that these awkward movements are nothing but neurogenic origin at most of the times, and or in discussion with your colleague or with your professor or during grand rounds or clinical rounds, you will find out that most of the times these are called movement disorders. So movement disorders are of two types. One is hypokinetic movement disorders, second one is hyperkinetic movement disorders. Classically, Parkinsonism, even though it is seen as tremor means a shaking like this, it falls under the category of hypokinetic movement disorders, whereas today's topic is about hyperkinetic movement disorders. So by convention, we are not going to discuss Parkinsonism or Parkinson disease in these settings. So our topic is limited to these 6 types: tremor, dystonia, chorea, athetosis, myoclonus, tics. Before embarking our journey, I would like to tell you that you have to examine or see the patients as much as possible. How many times it is possible, or in mornings or evenings you have to attend the postings. If at all you are not getting the time, please go to wards in evenings and examine the patients, and you can take the help of your colleague or your friend or seniors like final year students, or even those who are doing internship, or if it is a teaching hospital, postgraduates. So essentially, medical education is a team approach, because nobody is going to learn overnight, and all that subject is cannot be taught by professors or his department. So it is always a two-way process. First, you should have interest in learning about the intricacies of medicine. So today's topic is about neurological. One of the most common problems in neurology, just now as I have told, a patient coming with awkward movement. Initially, it may look somewhat ambiguous to you, but over a period of time, with keen observation and interest, you definitely are going to master it. After all, neurology is one of the, though complex subjects, it can be simplified and you can apply in general practice. Okay. So first type is tremor. So what is tremor? By this time you might have heard about a tremor, or yourself might have experienced the tremor. So when you applied for NEET exams, or thereafter when you joined a new medical college, when you entered your classrooms or hostel, you might be having palpitations, sweating, shaky hands. So these shaky hands are nothing but a form of tremor, anxiety related tremor, but it is not pathologic because it is situational. On the other hand, in spite of all these things, means a usual social status is normal, still a person experiences tremor either in resting phase or when he or she is walking or in volition phase, then it is pathological. One thing I would like to tell as far as these hyperkinetic movement disorders concerned, the basic concept is that most of times the lesion is in the region of basal ganglia. So basal means at the base of the cerebral hemispheres. There these things happen, and it is a heterogeneous structure. So there are subcomponents that we are going to discuss in later sections. So as of now, we limit ourselves to broad divisions of these hyperkinetic movement disorders. Coming to tremor, other than our Parkinson disease, it is essential tremor. You can see many elderly people having a tremor in their hands, just walking like that with a tremor. But first, essentially, you have to rule out peripheral neuropathy because of diabetes mellitus or other comorbidities. So tremor is very fine, 6 to 10 hertz. So actually we can't monitor electronically, it is just observation. It can be done in electrophysiology settings, and in most of times it is limited to upper limbs. Patient coming hands like this, shaking like this, whenever he is trying to hold something, getting hands, getting tremors in hands, and sometimes they may spill over also. But so far, in spite of extensive research, Many genes have been proposed for the etiology of essential tremor, but none has been completely proven. Often you can elicit a family history. For example, if a person is having this tremor, his brother or his parents might be having the same features of tremor or some other movement disorders or even memory loss also. In majority of the settings, you can see same problem, same complaint. My father is having a tremor, my brother is having tremor, they have died at the age of 70 years, like that. But in spite of extensive analysis of genes, no single gene has been found out as a culprit for essential tremor. So common clinical spectrum, but might be of different genetic etiology. It is known as phenocopy. So essential tremor is a typical example for phenocopies. Okay, got the point? If you can remember up to this in your second year postings, it is more than sufficient. Coming to treatment, it is quite simple. Either you can give beta blockers which will attenuate the tremor, or primidone. Sometimes we have to combine the therapy also. In beta blockers, most of the times either we give propranolol or what is the most recent one, metoprolol. So in low doses they are sufficient. Okay, this is about essential tremor. Let's go to another movement disorder. Dystonia. Name itself tells. Dys means somewhat disturbed. Tonia means tone in our body. Here it is pattern. I just can't mimic dystonia. It is patterned, it moves like this, it moves like this, hands will be going like this. So one side muscle will act, after some time opposite muscle will act, either in upper limbs or lower limbs. So at the same time, if you have got action of agonistic, means one side, antagonistic, opposite muscle action, then you will get this dramatic appearance of dystonia. Typical example you can see dystonia is in Michael Jackson dance movements, but that is voluntary and deliberate, whereas same movement if a patient has got, it has got dystonia. Okay. So most of the time it happens when patient tries to walk or tries to pick up something, when he bends, sometimes he may fall also because of dystonia. Because in that setting patient may not have proper counteractive muscles for the maintenance of balance. And sometimes what happens is that, a typical example I will tell, a patient tries to pick up say this pen. So how he approaches pen? He approaches like this, he holds like this and he goes. At the same time it will progress to leg also, then he may fall forward. So it all appears as a dance movement, but it is a pathological disease. So that is known as overflow. So overflow of what? Overflow of required muscle action. So here the patient wants to take a pen, but in spite of that the movement progresses from upper limb to lower limb and he falls. So this is known as overflow. Over a period of time, God has given many tricks that they can at least protect themselves from such falls. For example, again same example I am going to give. Dystonia, I am going to held this, it shoots like this. When I am touching this with the opposite hand, sometimes it will get normalized, it gets relaxed. So patient learns such technique that by touching that affected part with the opposite one, it becomes normal. So this is known as Geste Antagoniste. So if you tell this point to your professor, I think you are going to get a gold medal in general medicine, or at least in neurology in your future. So again the problem is in basal ganglia, but which part, that is left to discretion of neurologist, because there are a lot of therapies which can be given for dystonia. Among them are, first one is levodopa, the same levodopa which we give for Parkinson disease, where patient walks like this, very slow shuffling movement, tremor like this, and In medically refractive cases where even levodopa stops functioning, there is one technique known as deep brain stimulation performed by intervention radiologist or neurosurgeon. This deep brain stimulation is of two types. One is surgical, second one is MRI. So, surgical and magnetic. So, whichever option is there, one can choose. In India, most of the times we do surgical. Nowadays, with advent of evolution MRI, so we are doing with MRI, deep brain stimulation. So, with these techniques, patient is going to have dramatic relief. So, coming back to dystonia, dystonia as I have told, it can be either isolated, only patient is having dystonia, but in some settings patient will have other forms like tremor also. So, dystonia, it walking like this, then it goes like this, and food will spill over when he tries to eat, it will he will touch all over his face. So, such settings are known as combined. Combined means other forms of movement disorders like tremor. What other forms we have got? Chorea, kind of those things. So, it is clear one is a isolated version, either it can be limited to only one part of the body or it can be general, means all over the body dystonia is happening, and combined means combined with other forms of hyperkinetic movement disorders. Clear? Okay, let's go to third part. Chorea is a jerky movement disorder which often resembles like a dance. You might be hearing this word chorea, choreographer for many dance movements in our movies, kind of those things. So, this chorea, this word is derived from Greek language, essentially means dance. So, this patient appears a little bit have jerk movements and walking like this, but in fact that is a movement disorder. Sometimes they may trip over. One of the things that is responsible for chorea is this Huntington's disease. In Huntington disease, what happens is that there is expansion of CAG repeats of Huntington gene over chromosome 4. Over generations, they do expand. Huntington's disease is a disease where anticipation occurs over generations of families. For example, a person is having CAG repeats of less than 20 normal, from 20 to 30, 30 to 40, over generations, from father to his son to his grandson, these repeats are going to increase. So, once it exceeds 30, these movement disorders are manifested. Okay, clear? This is one of the causes of chorea, Huntington's disease. So, that is why I have discussed it. Coming to treatment part. Again, same dopamine blocking agents. So, what are these dopamine blocking agents? Most common utilized is tetrabenazine. And recently there is a good molecule which shows much hope for this one, that is known as sigma 1 receptor agonist, Propido. From second year onwards till final year, this is more than sufficient for an MBBS graduate. We need not mimic a neurologist. Another interesting one is Myoclonus. Most of us, almost in 100% of population, everybody will experience this movement. Just guess when we are experiencing this one, especially while we are going to sleep. For example, when you are sleeping, suddenly we may react like this, and while waking up also sometimes we will wake up like this. This is nothing but myoclonus. Myoclonus means myo, muscle, clonus means jerky movement. It happens but without repetition. There is no pattern. Previously we have seen there is a pattern in tremor, kind of those things. So, these are physiological states what we are experiencing while going to sleep, having these myoclonus. On the other hand, when patient is quite awake, suddenly they may trip over, fall like this. And there is one more entity known as negative myoclonus. Sometimes while patient is sitting, simply he may collapse down. While standing, he may suddenly collapse. So, this is known as negative myoclonus, means loss of muscle power. So this jerky movement is positive one, whereas sometimes loss of muscle power can lead to falling of the patient, leading to injuries. So in both conditions, we have to suspect myoclonus unless proved otherwise. Again, coming to treatment, it is GABAergic, means stimulation of GABAergic neurons with our agents like levetiracetam, valproate, benzodiazepine agonist, clonazepam. So all these agents are, to some extent, they are protective. Is it clear? We will go to next session. Now let's talk about tics and end this topic of movement disorders. Tics. Similarly, like previously what I have seen, that is dystonia, sometimes many people have got tics. Tics means rapid stereotype movements, and one among them is echolalia. For example, if I am speaking something, the person who has got this one, he will repeat my words. If I say something okay, he will also say okay, in spite of there is no purpose. And second one is echopraxia. Praxia means movement. Echo means reflecting. For example, if I am keeping hand like this, that person after it also he keeps hand like this. If I smile, he smile. If I cry, he will also cry. So these are nothing but tics. They look quite amusing, but they are socially disturbing. Like this Coprolalia means uttering very filthy words because they have no control over them. So uttering filthy words, especially with such settings, one has to suspect tics. In one childhood condition, actually etiopathogenesis has not been found, that is known as Tourette syndrome. Tics have been seen, especially in males, often happening at the age of 5 to 7 years. They peak during childhood, means increasing disabling tics, means trying to mimic others, saying obscene words. But as far as current science is concerned, there is no definitive treatment. Few physicians have tried clonidine, alpha agonists with a partial relief, and few people have tried with atypical antipsychotics like risperidone. But as of now, there is no proper treatment for this condition. So with this slide, I would like to conclude for today, because I want to keep this discussion brief, especially during second year or final year postings. The topic of neurology appears quite, you can say, overbearing for us. So to summarize, these are the 6 things. If you can remember, it is more than enough. Tremor, dystonia, chorea, athetosis, myoclonus, and tics. So choreoathetosis is a common spectrum. Remember, the pathophysiology lies in this part of the brain, basal ganglia. If you remember, this is more than sufficient. Thank you very much.